Welcome, everybody, today. I'm glad to have you here and be able to talk to you about something that's very, very important to me. And I'll go ahead and share my screen, which is the safe care and education for caregivers at home. And I'll also extend home as into the school as well. And caregivers, meaning all kinds of caregivers, nurses, parents, school nurses, altogether is included in that caregiver title. So let's go ahead and get started here. I have no conflicts of interest, not discussing an adult label, and no commercial support. The objectives today, so we're going to be reviewing indications for tracheostomy. So what leads children or even adults to get tracheostomy tubes, a little bit on the history. And then how to facilitate airway patency and health if you have a tracheostomy tube in the airway. Components of effective training and learning and education for all types of caregivers. And then what I call the key here, which is to review skills needed to resolve airway emergencies. So I'm going to set the stage a little bit here. You know, first, usually you don't have conclusions at the beginning, but I'm going to have the conclusions at the beginning and at the end because I think the conclusions help set the stage here for what we're talking about and things you should keep in mind as we're talking. I think one of the things, the most prevalent things I have heard over the years for education in general, but certainly for tracheostomy care and learning, is that people don't know what they don't know. And that really came true to me, too, when I did a survey at our home care company of, like, what do nurses call for? And this was the prevailing theme, is that nurses don't know what they don't know. And so if you keep that in mind, you should be, as an instructor, be prepared to think about all of the content of what they might not know for basic care and emergency care. And if you don't have that basic knowledge, you really should think twice about teaching new folks. You also should, as an instructor, be able to critique what they're going to show you back, return demonstration, and be able to simulate, watch simulations, give them feedback, recognize mistakes, and then also congratulate new learners. I think also over the years I've learned that people are pretty nervous when they're learning. They can be, some are, but you know, people are nervous if they're having to do a return demonstration or a simulation, and a scary simulation. It's nerve-wracking. So please congratulate them. That's my call to instructors. As far as caregivers and nurses, one thing I say to our families all the time is I tell them, do not leave your nurses alone until you know what they know. And to nurses, I would say the same thing in a different way. Do not work in a home independently until you know basic care and emergency care. Inside and out, no gaps. You have to be able to think on your feet. You have to have some muscle memory so that you don't have to think, what do I do, what do I do? You just know what to do. And that muscle memory comes from the simulations, the return demonstrations, and repeating those. Maintain high expectations through your employer. So your expectation for your employer is that you should teach me what I need to know. And there should not be any gaps. That's initially and then ongoing. The number 2 point here is standardized education for all learners is driven by best practice and best sources of information. Also part of my sort of discovery several years ago of like what's going on out in the community, I think it was 2011, and since. But not everything on the internet or YouTube is true or best practice. So I've seen several YouTube videos that make me shudder or make me nervous, or some that actually are very good. But until you know what you need to know, how do you tell what's true in the internet or YouTube? So you have to be very careful. Parents find these things a lot too, and there's a lot of work to do to kind of correct information once they've gotten on the internet or YouTube. Evaluate the source. Social media, these parents are very connected, as are nurses. And I know from international positions that there's different regions and countries do things very different, and they can still post on these sites. It doesn't necessarily mean it's a bad thing. It could just be a different thing. But until you know, you can't evaluate it. There's practice guidelines as sources of information. So American Thoracic Society, Global Tracheostomy Collaborative, both of them have, well, ATS has position papers. GTC has videos that you can watch and learn from, and that's a valuable source. And it's a source that's well recognized and as leaders within tracheostomy care. When was the information printed? So again, on this journey several years ago, they have, many of the agencies had handouts from the late 90s, and they hadn't been updated. And so it was an opportunity to give them updated, but when was the information published? This information doesn't change with great speed, but it does change over time. There might be new things out there. You have to know your experts. So you have to know that the information you're going to get is from a credible source, and you need to network with them and know. So if you have a question, who do I go to? And then challenge those experts so that if you found a differing opinion, let's say you did watch YouTube and you found something different, challenge those experts with what you think you know so that you can either be affirmed or they can give you a differing opinion. And then experts that are out there should also be humble learners, which kind of goes with challenging the experts. We should always, even experts who know this, should be humble to accept new information. And then translation of printed materials for families into primary language of care is really important. The number 3 point here is educationally plan for complacency and airway emergencies. So an emergency can happen anytime, every day, at night. You never know. And just once should be enough motivation to be prepared all the time so that you don't become complacent. Educate on and prevent complacencies. We drive that home within our Tracheostomy-Safe Emergency Airway Management Class 2 that it's really about complacency and that we haven't had an emergency, so we probably aren't going to have one, or the last one we had was 6 months ago. We have to plan for that educationally. And we know, and there's several articles that document this, that caregivers want people who can think on their feet. So they don't want caregivers, other nurses, other people caring for their child who can't think on their feet. So that should be a goal. And see one, do one, simulate many should be the new mantra for how we go about learning and practicing. So we see one, we do one, and then we simulate many until we have that muscle memory. This came out too with looking at our home care company years ago, is that nurses didn't know when they should worry. And so don't be anxious, don't be, shaking in your boots, but at least know when you should worry, like what does a problem look like? And do I have the correct machines and supplies at my fingertips for both the routine care, and very importantly, the emergency care? And this was a quote that one of our pulmonologists used to describe trach and trach vent dependent children by Henry Wadsworth Longfellow. There was a little girl who had a little curl right in the middle of her forehead. When she was good, she was very, very good. And when she was bad, she was horrid. And that's not for all trach kids, but for many. That if that trach is out, if it's blocked, you can get horrid pretty fast, depending on what your medical problems are. That'd be most. It's not all. You should know that, though. You should know which child is going to be horrid if that trach is plugged or out. But otherwise, most days, trach kids are living here. They're happy, they're playing, they're fine. But if that tube is out or blocked, the potential to become not fine can be really quick, depending on the child. Let's start then talking a little bit now about trach tube basics and a little bit on the history, which I always think is really interesting. So in these handouts, I'm going to give you a link to our tracheostomy education book towards the end of this presentation. But these are pictures taken from that book so that you can understand how the trach fits into the airway here. And this is handouts that we give to families within the book. We give them a book. So that, the words that roll off our tongues as healthcare providers don't necessarily always mean something to families. So at least they have something written that they can go back to, because many of them are getting nervous about saying they don't understand or they don't remember, and different reading levels. And some of these words can be challenging for different reading levels. So this is just a sample of our handout that we give parents, along with the tracheostomy tube. Here's the pilot balloon, and that is a balloon that inflates the cuff, which is, you can, it would be right here if you could see it better. Often chewed off by toddlers, unfortunately, and that's a little bit of a problem. But this balloon, it's not like a Foley tube. It does not keep the trach in place. A pilot balloon, if you fill that up, helps the air to go down into the lungs, so the air takes the path of least resistance. So we fill this balloon to make the air go into the lungs instead of leaking around the phalanges at the neck. And then this obturator, that is the device you put into the trach tube to help guide the trach tube into the stoma when you're replacing it. And you quickly take it out then after the trach is, after the trach is in the stoma. So that's just basics I wanted you to hear about. These are plastic, and in fact, this is a flex 10 trach tube because it has a little bit of a flex here. This is where it sits on the neck, and it comes out beyond the airway, which is good for babies who have chins that are kind of in the way. Back in older times, there's still metal trachs, but this is a sample of a brass trach that I found, and then another set of tracheostomy tubes that are metal from way back. That's an old pilot tube. Or I'm sorry, obturator, sorry, that's an old obturator, very interesting. You can still see metal tubes, but they're pretty rare. They're not in pediatrics. If they're anywhere, they're in adults. If we look back at the history, so there were Egyptian engravings that they found back in 3600, and then saw it in written 2000 BC. And then Asclepiades is the first person that was accredited with the idea of a trach. And then we take a big jump. So in Italy, somebody put in a trach tube, or a tube anyway, let's say, for a tonsillar obstruction. First pediatric trach tube. In 1718, a German surgeon coined the word tracheotomy as the procedure. And then that was mentioned in 1765, a possible use of a tracheostomy in peds. I did include in here between 1765 and 1900, when George Washington was in the process of dying, he probably had epiglottitis, which was obstructing his airway. His physician actually thought of putting a trach in George Washington, but thought different about it when he thought, this is a president, and I'm not going to make such a bold procedure on a president when I really don't know what I'm doing. So he didn't do that. I thought that was interesting. In the 1900s, it became more of a standard surgical procedure, and in 1965, introduced into neonatal medicine. And then going back and looking, you know, this is a long time ago, and records all the way back. I thought we were in the mid-'80s for our first discharge home, but the one we could find was May of 1990, the first discharge by Seattle Children's Home Care with a trach patient. Now, I think there were other earlier ones, but maybe with other companies. And so that's the best I could do on that. And then if you look back here, this is actually an important person in the development of tracheostomy tubes. This is a picture of children living in the hospital because there was no going home. It was in 1938, probably, I'm going to guess, related to the polio pandemic, but I'm not sure. So children had to live in the hospital back then. And then, you know, mid-'80s or so and better, they've been able to go home. So what's the reason for tubes to be placed? So I'm going to divide it into obstruction and chronic ventilation. Most things fall within that. This is not an exhaustive list, but this is a pretty good list. And airway stenosis, and this might be a little hard for you to see, but it's really important that we teach to the different grades of subglottic stenosis. Most of subglottic is acquired and sort of trauma from the trach tube being in the stoma and batting around. Not all the time, though. It's able to be graded on 4 levels. So grade 1 is 0 to 50. Grade 2 is 51 to 70% obstructed. Grade 3, 71 to 99. That's that very small hole. And then grade 4 is no airway. This makes that trach tube the lifeline, especially when you get into here. 1 and 2, you might not see trach tubes if it's just for obstruction. 3 and 4, you probably will. Very important to know why the child you're caring for, or why your child has a trach tube, because that guides the emergency response. It could be from a large tongue or a small jaw. So small jaws tend to place the tongue posteriorly and have that be a block to the airway. Vocal cord paralysis, sometimes that's acquired by repetitive traumatic extubations and traumatic intubations that would do some damage to the vocal cords. Airway floppiness or malacia can be the trach or the bronchus or lower. Secretion removal. So those are kids that are maybe cerebral palsy kids or similar that have a lot of secretions that plug their upper airway, and we need a tube to be able to remove them. We have airway scarring and trauma. That can be, we've had a child swallow a battery that ended up burning through the airway. Compression by vessels, so there's compression by some of the cardiac vasculature and the area of the airway that can cause an obstruction, and then certainly other cancers. And then maybe you need a trach, but you might have some of these things, but if you also have chronic ventilation, so we can't send kids home on ET tubes, we have to put a trach in. For lung disease, if there's paralysis like a spinal cord injury, muscle weakness such as SMA, spinal muscular atrophy, or myotubular myopathy, again, malacia for chronic ventilation. If you have abnormal respiratory drive like congenital central hypoventilation syndrome, or a traumatic brain injury, ineffective oxygenation such as a diffusion defect or cardiac defect, of abnormal rib structure. So sometimes kids are born with not all the parts and pieces all in the right spot or functioning like they're supposed to, including abnormal diaphragm. So we certainly have had children like this who have to have chronic ventilation in order to survive. Who are the best educators? And it's simply the experts. But you have to know your experts. And there could be nurses, there could be RTs, and I want to be really clear that it can be parents. Because I think Seattle Children's has a really robust training program. And after these parents get home and kind of get their feet underneath them, they're really strong experts. And certainly there's doctors who are also experts who've been there, done that. So know your experts, evaluate your experts, and challenge your experts, again, when you get new information to make sure that we're all doing the best that we can, so that everyone receives the same content, has the same expectations. And so this is just an example of how you would go about training. So let's just say it's a trach change. We instructed them on this date, who would we instruct. They did some return demonstration. They had to have some prompts. So we did another return demonstration, no prompts needed. And then we did simulations and a reminder to, check the trach cup before inserting, right? That's a check step. And then when's the next review date? So this is a sample of how we incorporate both, learning, observing and return demonstration, and then also simulation, which I think are all very important components of any education, whether it be trachs or anything else. I'm going to be putting some pages up. We could spend hours and hours going all of these different pages on how to do things. Again, you'll get a link to the book at the end that you can pull this up online and certainly go through it. Way more pages in the book than I'm going to be able to show you today. So I want you to focus on chest rise. I want you to think about chest rise. Everything is about chest rise, making sure that the air is going in and out. And we retain that air by suctioning. Inline means there's a catheter in line with the vent tubing, or simple catheter, which is just outside without vent tubing. How to use oxygen. So these are all bullet points on our teaching for all of our parents. Resuscitator, bag, and function, and how to bag suction with two people. And so you have some clip outs here of what parents are actually taught. I think the trach care, the trach education for parents is somewhere around 10 to 12 to 14 hours. It depends. We go at the level of the family and how fast they can go. So it's certainly not our agenda or our intent to speed anybody through this. Counting the respiratory rate is really important, and it's really quite confounding to families. As some nurses, doctors, and RTs, the rest, something that's very natural to us is actually quite unnatural to families. We teach them, and then knowing what normal is, because that child's normal might be 40 when they're 1 year old. That's not normal for most 1-year-olds. So their normal is going to be different, and that's important for them to know. The use of oximeter, which we generally order at all times. We have lost children over the years, unfortunately. Very sad when they don't use the oximeter because, again, emergencies never happen, right? It's that complacency factor. We teach signs and symptoms of distress, which, again, is different depending on the child. I teach our families a lot before they go home. When we lift up the shirt and look and see if you walked into the ER with that chest wall now, everybody in the ER would be nervous. You have to represent this as your child's normal. And then what does an infection look like and how to collect trach aspirates? Because it's not if but when, really, when trach kids are going to get a tracheitis, which is a infection in the airway, either viral or bacterial, sometimes both. Also on our list is CPT or chest physiotherapy, how to use an MDI with a spacer, how to use a nebulizer. So there's another page that I didn't put on here, but here's our drawing. Here's the instructions. And again, this is in the book, but this has gone over in all of our trainings. Trach changes. This is the lifesaver, right? This is keeping the trach in the stoma and making sure it's in the right place and patent. They talk about putting it in, taking it out, how to clean it, and problems. And, you know, that is a lot of information just in those 4 things right there, and very critical. Probably the hardest thing for parents to learn, and I would say even nurses, is it's shocking, right? It's shocking to put a trach in and out of a stoma, but critical because this is what saves lives when we've educated how to change that trach. When to change it, what does it look like when it needs to be changed? If you go across the country, there's different standards of how often they're changed. Some do weekly, some do every 2 weeks, and at Seattle Children's, we order monthly for most kids. It's not all, but for most, it's a monthly trach change. What's different about CPR is it's for trach kids, it's still ABC, airway, breathing, circulation. Because in children, the airway is likely to be the culprit, is likely to be the problem. So establishing an airway is what we do, and you see the CPR checklist here. Airway, breathing, circulation. So those are the really important parts of making sure when you're thinking on your feet that you've established an airway and breathing and then returning to circulation. And then simulation. So in the car, out of cell reception, block tube. I mean, all these scenarios that you could think of where you're going to get in trouble and you might not have all of the things you need. If you're out of cell reception, what are you going to do? What are you going to do if the tube is blocked? We have our family's room in, and we teach it in a way that if you're on a desert island and you have all the supplies that you need, do you know what to do? You have all the supplies. Do you know what to do? It's not a test for us. We're not testing them. It's a test for themselves to make sure that they're ready, which should also translate into home nurses, nurses in any setting, making sure you're ready to work independently. We talk about home readiness, so we either say the dedicated cell phone or a landline phone. Landline phones are not as prevalent at all as they used to be. And most people are using cell phones, which are very people dependent, very electricity dependent. So we ask them to really think strongly about a dedicated cell phone that's in the room, doesn't leave, always charged. It's there for 911, and it doesn't leave the room except for any other thing. It's always in the child's room. You can't rely that mom's always going to be there with hers, or maybe it's not charged. Maybe the bill wasn't paid. The nurse could have forgot theirs at home. So all the variables of what human beings do, we want to cover that base. We talk about communication with nursing agencies. So, you know, it's kind of it's a deal, really, to have nurses in your house. Kind of a mixed blessing is how I talk about it with families. Very wonderful in lots of ways, but also very challenging in some other ways. And communication is really the key to making it work. So we talk about communication skills, how to deal with parents who are not happy, who are very happy, and praising that. And what else is going to come up as far as, you know, differences of opinion on care needs, and how do you work through that? How do you maintain professional boundaries? We talk to families about, you know, it's probably okay to go over for their first birthday party. You know, there might be difference of opinion on that. But going over for holidays, meeting for coffee, going out to a movie, really not the relationship you want to have with nurses in your home. You want to keep that more on a professional level. There's some crucial conversations that have to have with families, and you want to be able to have those conversations that sometimes are a little different when you're friends. So we talk about maintaining be friendly, but don't be friends is how we phrase it. And then the EMS response. So the Port Fire Department people, they roll up. Their EMTs are the first people to get there. All firemen are EMTs. But they're not paramedics, and even the paramedics are nervous and sweaty when they come up for a response for a trach vent child, so we prepare the families for that. Part of our preparation, though, too, is getting the information into premise files. So we let the fire department know before they go home, hey, there's this child going home. They have, this is what their airway is like, which I'll show you in a sec. And I want you to know they're there, and they always need a paramedic response. So we prepare parents for that. We have had before, when we didn't do that, there were some unhappy surprises about EMTs not being able to work with airways. So we want to always, we don't want any surprises. Community emergency preparedness, both, we talked about phone, but, parents are everyone's really reliable on power. Whether it be the school, hospital, we have huge backup systems here, but not true for all families. So we prepare for families to think about where are you going to go, where are you going to drive to go get some power. And then this one is one of my favorites. Why does your child have a trach? Why does the child have a vent? This is so important because knowing this helps guide emergency responses. If you know they have a trach because they have subglottic grade 3, again, which is up to 99% blocked, you know what that child's going to be like with that trach out, right? Why do they have a vent? And it's a very interesting responses that you get back. I remember asking one patient, family before, why they had a vent. It was actually a nurse at the house. Why is this child on his vent? And the nurse said, well, because the parents want him to live. And I said, yep, that's true, but why is he on a vent? And understanding these things are critical because when neither one of these are working, if the vent fails or the trach is out, you know what your problems are. So you should know this as any caregiver or any educator, why the child is trached and why they're on a vent. Critical. We also have here what is a PSO, or patient-specific orientation, where they spend 2 hours with an RT. This is before they go home for the first time. They spend about an hour with the nurse, about half an hour to an hour with therapists, and about 15 minutes to half an hour with a dietitian. And we do that not as education per se, but we do that to get everybody off to the best start possible so that they know the specifics of this child. It's the agency's job to train them. A hospital does not train people before they go home. They do not train caregivers, but we orient to the child. So resolving airway emergencies, right? This is where the rubber hits the road. Why does the patient have a trach tube? We've talked about that. What happens if it's out or plugged? What if the vent or the suction machine malfunctions? What are going to be your problems if this happens? And then do you have what you need at your fingertips to save this child's life if there's an emergency? And am I prepared as a caregiver to start CPR or any other care needs that are emergently needed for somebody with a trach tube? Because knowing these guides your interventions. We talked a little bit about, being prepared to know why you have a trach and what the emergency plan is. So at Seattle Children's, we have everybody prior to their first discharge, I would say 99.5% of kids going out of the hospital get a trach-safe airway diagram. Now, we also send to the fire department. It serves to put in the premise file so that as paramedics are rolling onto the scene, they know that this child is a trach. This is the most important box. Can the child be bagged through their nose and mouth? Because that's not true, right? For if you have a subglottic 3 or 4, you might not be able to be bagged through your nose and mouth, and then you have to bag the stoma instead. Or do you need an oral airway in order to bag? Can the child be orally intubated? Again, not true for everybody. So this is the most important box. And if you don't have a form, create this for yourselves, at least on the plan of care or some other way that you know the answers to these things. When we made this form, we said, we rattle off a lot of words like tracheomalacia, bronchomalacia, subglottic stenosis, all those things, right? And parents nod, and then they say, I don't know what that means to other people. So we put the airway diagnosis here, and then we explain it in English, if you will, so that parents understand, helps them understand why they have a trach. And then these are just quick steps. And one of the things we teach with alarms is respond to alarms, but don't worry about the alarm. Look at the child first. An alarming machine can wait. If the trach is blocked or out, replace it. Suction, equipment problem. So this is just a really quick. There's lots of skills within that. But if you go down this way, you'll be able to have a good tool to respond to an emergency. We have a Trach-Safe emergency airway management class. We have that 4 times a year. And mostly home nurses and school nurses come. And this is just some of the settings, some of the things that we do within the class and kind of an overview of the class. And the next one is on 6/5/23. We take 16 to 18 nurses from different settings, and we really spend 5 or 6 hours just on emergency care. Because again, that's where the rubber hits the road. That's where they get horrid. Part of airway safety, and we stress this in our class as well, is the go bag. And it's not in the car or upstairs or downstairs or in the other room. It's right next to the child. It's not the everything bag. It's just an emergency bag. So it doesn't have the T-shirts and the crackers in it. It just has the things that you need to respond to the emergency. And then you need to know the emergency plan. So it's right next, it's fully stocked, it's checked daily because people do take things out and they don't tell others. It has all the correct sizes because these sizes do change over time. And then the person responsible for the care of that child knows the emergency airway plan. Very important. We teach this, we stress this in the class. Is the trach in? Is the trach out? Or chest rise? Starting with this evaluation, and I put this picture here because if you've got a stoma that's being covered by dressing and there's a problem, you can't really tell trach in, trach out. Rip that dressing out from under the ties. Rip, I say lightly, you don't want to decannulate the child, but pull that out so you can see. We've lost children because of the pajamas or the stressing, that people can't see the trach is out. Or during CPR, they can't see the trach is out. You can imagine if you're doing chest compressions, how easy it would be for a short little trach tube to slip out of that stoma. We've lost children during CPR when the trach tube is out of the stoma, but nobody could see it and nobody looked. Very important within CPR that you're double checking that you can see that stoma. So get rid of that dressing. Chest rise, it's all about air going in and out. That's what it's about. It's about air keeping the child alive. It's about making sure that you have a mask over this, and this is how the C, a hand and a C, and then an E for the clamp grip. You can see how these fingers are thrusting that jaw open and up so that you can bag effectively. You have to know if you're going to bag the nose and mouth or if you're going to bag the stoma. That's part of that emergency care. So trach in, trach out, and chest rise. That's your really quick evaluation. You can really accomplish this within several seconds. Then I want people to have a preoccupation with failure. And so early failure points is about trach security. Is it in the stoma? Is it open? Is there adequate humidity? We talk about never having a naked trach tube. So there's HMEs, heat moisture exchangers, that can go over trachs. There's also mist collars, obviously the vent tubing, but we don't have any naked trach tubes. If you just take a breath through your mouth now, you'll feel how dry that gets. That does not promote airway health if we don't provide good humidity. It's also a risk of airway plugging. Trained caregivers are awake and nearby at all times. Emergency plan is in place, and everybody's ready to enact the emergency plan. We had one lovely family who came up with a whistle idea, and they keep their whistle at the bedside. And so instead of running to get people when there's an emergency, they just blow their whistle, which is a fabulous idea. You know, repetitive here, routine and emergency supplies, equipment at hand, medications are at hand, because sometimes it's not the tube, sometimes it's the lungs, it's the lung tissue, it's the heart, it's other things that medically lead to an emergency. You have to give those medications. And then the plan of care supports patient care and safety every day, all night. That's the lens we should use for those plans of care. So here's the link that I want you to have. I don't know, maybe Hyan, you can copy paste that into the chat or whatever you think is the best way, however, to get this out there so that people can pull this up outside. So it's about, 80 to 90 pages. I've given you little snapshots of what some of the pages look like, but there's a lot more content in there. And so this is a spiral bound notebook, very colorful, very well done, I think, and it's available for people who need to look at it. It's been an evolution, really, over time. All it really does is grow. And we think of more things like, oh, we got to put that in the book. So it's always open for scrutiny and for improvement. So here's some conclusions that I want you to remember. We started out with these, if you remember. People don't know what they don't know. So any education plan has to be solid and completely put together in a way that captures all the things they need to know for routine and emergent care. Then standard education. So it doesn't matter who comes into the office, who's at home, wherever they're being taught, that it's standard, it's driven by best practice and best sources of information. The internet is a wonderful service. We all use it all the time. Things on the internet can be wonderful, there's no doubt. There's also things on the internet that could be debatable as far as best practice or best sources of information. Educationally plan for complacency. People get complacent. That's what we do. We think about when you're driving, how do you drive now as compared to how would you drive on a driving test with the Department of Licensing, right? We get complacent. We do it differently. We don't do as much as we should do, put our blinker on as fast as we should. All the things that humans, the behaviors are that make us complacent. So education plan for that. Remind people you're going to be at risk for getting complacent. Don't go there. And then emergencies. Preoccupation with failure. What are the things that you can improve so that you don't have those failures? Part of our Tracheostomy class is a home safety station where we go over all of the wrong supplies and the right supplies that are at the bedside. So we have a simulation of a bedside, and we go over what is right and wrong so that the environment of care supports giving good care and that we minimize any risk of failures. And then the words I say ad nauseum to anybody who will listen is the trach in, is the trach out, and do we have chest rise? So that's the nuts and bolts of it, really, right there, as far as keeping these children and adults well cared for at home. So I will go ahead. If there's any questions, I thank you for your time. I thank you for your interest in listening to this discussion today. I'm always excited at the chance of trying to, help the world be a little bit better in any way that we can to help these kids. They go through a lot, families go through a lot. And if we can make their days just a bit better by giving them our best, then we should do that. So here's my contact information. I'm happy to talk to anybody or give me a call. If you have any questions or if something wasn't clear, I am happy to talk to anybody. So I think, I know, Hyan and team, if there's any questions that are already in the chat or if anybody has any questions, you probably should raise your hand. I'm thinking, Hyan, was that your request?
Yes, if
Okay.
you want to come off mute, go ahead and raise your hand. We can call you. You can come off mute, or if you want to put your question in the chat, I can read them out on your behalf as well. The questions haven't come in since throughout the talk, so we don't have anything quite yet. I did put
Okay.
the link for the Tracheostomy handbook in the chat, so if you want access to that, you can click on that now. But the link is included in the course handout, which will be uploaded to our .org page, or it should have been, or maybe sometime this week it will be uploaded, so you can have access to that. Just a lot of gratitude to Leslie for your work and your passion on this. Oh, I see a hand from Mary Lou Sheen. Mary Lou, do you want to come off mute?
Yeah, hi. Thank you for the great presentation. I am wondering, this is a large question, but what do school nurses who aren't necessarily the one-to-one caretaker of a child with a tracheostomy, what do they need to know? Should they take the Tracheostomy course, or what are your recommendations?
Well, I would love everybody to take the Tracheostomy course, so that's an easy answer for me. So I think it's a really good course. It is popular, and so there is some competition to get into the course, but I think there's still some room, I believe. High-end would know if there's still any availability for the 6.5 course. The one after that, I think, is 8.28. So yeah, please, it's always a tool, and it prepares you for emergencies. At school, it depends on the child, because some of our adolescents don't want nurses following them around at school. That makes sense. But generally, what we, at least from this facility, is that there is a one-to-one nurse with the trach child at school. Again, that's to deal with emergencies. So most of the time, they're just fine. They're doing fine. They're doing their schoolwork. They're playing out on the recess playground, having a great time. Or they're in the wheelchair. There's a continuum. That is a one-to-one nursing, so it's not good enough to have a nurse in the building. There is somebody next to that child all the time. That person, whoever their employer is, and I find the people that employ school nurses need some more robust education before they send these nurses into schools. There's a lot of work to do there. So as the school nurse, if you're prepared for standard basic care and care that's for emergencies, if I was you, I would quiz this nurse that's at the school and say, what would you do if? What do you know about this? Do you have the go bag? Have you checked the go bag? Do you have everything you need for emergency? Where does this child get bagged? Do they get bagged through the nose and mouth, or do they get bagged through the stoma because they have an upper airway problem? So if you're prepared in that level as a school nurse, that would be golden. That we sort of double check the nurses that are coming into schools who have varied educational opportunities to be quizzed and be verified. And if they don't know, we need to make them feel bad, but we should get them the information they need. And then maybe they're not prepared to be with that child on that day. If they cannot respond to an emergency, if I was a school nurse, I'd have to call mom and say, Mom, you're going to have to come pick up your child because this nurse who accompanied them today is not ready to respond to an emergency. That's what I do. That's what I would do. Does that help?
Definitely, thank you, and I will
You're welcome.
definitely be recommending that they take the Tracheostomy. I already have talked about it a little bit, but
Yeah.
definitely wanting them to take that. Do you plan on ever offering it more than 4 times a year, or?
I would love to. I would offer it. It's up to high end, right? I'd love to offer it every 2 weeks. But
it's not up to me.
Well, that's true. There's lots of people it's up to, right? I would love to offer it every 2 weeks. I think there's an audience for it. I would love to do that. But it's, all the things that are constraints with trying to grow programs. You guys, all workplaces, you know what that's like. So similar challenges, but we do want to increase instead of the number of times per year, is increase capacity so that we can get more people into the class.
There's a question about the current situation with home health nursing services, all the families that I know are really struggling to get home care. So any
Yeah.
updates on that?
Home nursing is really tough. There's not enough nurses. There hasn't been enough nurses. I would generalize that to, going back to, I've been working on in this realm specifically really for 25 years, but always with trach kids going back 30 plus. And it's always been a struggle. And it's been better than sometimes, worse than others. COVID has made it very interesting in a worse way, I guess I would say, because nurses have left the profession. A lot of the healthcare people have left. What I'm trying to work on is what's new models of care, which is trying to develop a system of care and education for non-nurses. So there's several states who are doing this. There's several states that are doing it better than Washington, and Washington has some catch-up to try and improve access to care for these kids at home that's outside of the usual nurse, RN, LPN. And part of that is paying parents, which there actually is House Bill 1694, Section 11, is a feasibility study that we are going to conduct this next year to be given a legislative report by 12/31 to try and put together what it's going to look like to pay parents, which helps those parents, and I don't think they're going to get rich off of this, right? And that's not really the point. But for parents who can work for a livable wage instead of having to go to work, it just helps life be more manageable. It helps prevent eviction, which we've had a recent one in the last month from a family who mom couldn't go to work, single mom, evicted. And it would be a whole different story if we could pay her. So those are things that we're working on. And we'll keep working on them. I'm persistent.
Thank you. Autumn asked about providing the Tracheostomy class, I'm assuming, on the east side. On my end, we don't have any plans right now.
Yeah.
But I think Leslie has been trying to advocate a mobile class. I think there's future work.
I have in my mind a Tracheostomy van that has Tracheostomy written on the side of it, and we take the van around the state and teach this emergency care, but that's just a kind of a pipe dream for right now.
And I think you had questions about capacity for our class in June and August. June is full right now. August, there's still space if folks are interested in attending. And I put the registration link in the chat as well.
And it's open to register for the August class right now?
I thought so. Mm-hmm.
Okay.
All right, what other questions do you all have while we have Leslie here? Eileen says, best wishes for success with your pipe dreams, Leslie.
Thank you. Thank you. I'm anything but persistent.
All right, I think if there's not anything else, if you think of anything afterwards, Leslie's information is going to be in the slide deck. That'll be on our .org page. And thank you so much, everyone, for attending today, and we hope to see you next month. Thank you, Leslie.
Thanks, everyone. Thank you.